So today we had the privilege of hearing you talk or dive deep into the centralized pain disorder, specifically fibromyalgia.
Right.
And I have to admit, from an advanced practitioner standpoint, I have a bias when I hear a patient, their diagnosis list include fibromyalgia. I think we oftentimes want to stereotype that patient. But I think what you discussed today was extremely eye-opening. And I'd like you just to talk a little bit more about what fibromyalgia is.
Sure. And I don't think you're alone in that stereotyping. I'm guilty of doing the same thing too. And I think these patients can sense that, right? And because they've been stereotyped by a lot of people. What it is, and I guess a segue into that is a lot of people think it's just in their head. And in some ways it is. It's a central nervous system disorder, right? Which is inherently in your head. But there are, in fact, differences on fMRIs. They have lower amounts of gray matter in their brain. And so there are structural changes we can see in fibromyalgia. But essentially, what it is it's a central processing disorder. So these patients feel more pain when, both to a painful stimulus that's maybe light pain, they feel it as a lot of pain, and sometimes to stimuli that shouldn't be painful, like heat or cold, that should not be painful, they experience pain from. And so you can imagine walking around in a world where you're experiencing pain from things that shouldn't cause pain is not a very pleasant experience for these patients. So it's a central processing disorder where they experience more pain.
Oh. And I think in that same vein, when patients come in and they say they have fibromyalgia, sometimes we suspect that we don't know what's going on.
Right.
But there are tangible criteria in which you can use to diagnose fibromyalgia. Could you talk a little bit more about that?
Yeah. So there's not a blood test for fibromyalgia. So it's not easy. In some ways, it is a diagnosis of exclusion. You're ruling out autoimmune conditions like Sjogren's disease or lupus or rheumatoid arthritis, some of these other diseases that it could be. But if they're not checking those boxes, and then fibromyalgia should be suspected if they're having widespread pain. There are two classification systems that I'm aware of that are used widely. One is by the American College of Rheumatology, and you take those patients through a widespread pain index rating where you ask them about pain in certain sites in the body and give them a score, and then a symptom severity score where you ask them about other symptoms they have and how severe they are. All this stuff is easy to find online if you need to Google it. And you take those two scores, you add them up, and you can reach a diagnosis of fibromyalgia if you reach certain scores. It's a little bit onerous to do, but might be necessary in some patients. A little bit more quick and dirty way is the diagnostic criteria by the American Academy of Physical Therapy, where you ask them about pain in 9 different sites, and if they have it in 6 of them, plus mood problems or sleep problems, you can diagnose fibromyalgia. And that was a lot easier to do. So yeah, there are actually diagnostic criteria where you can definitively give a patient a diagnosis of fibromyalgia.
So I was lucky because I got to do family medicine before I came here. So you and
Nice.
I have something in common. But
Nice.
I found it always interesting when I would do like those point tenderness spots. They'd be like, oh, this is actually where I'm feeling pain, and just seeing like their eyes light up because they were like, oh, you're catching something here that maybe has been missed for a long time. It's kind of rewarding to be able to help a patient who feels unheard.
Totally.
Yeah.
That's like a very satisfying feeling to see almost that. And someone brought it up in the meeting we had before, but there's often tears when you discuss this with patients, and it's not because they've been diagnosed with fibromyalgia, like a disease that they're afraid of. It's they finally have a name to call this problem they've been dealing with for years, and they're often like tears of relief or joy that someone's hearing them, they have a diagnosis, and they can focus on steps moving forward. Yeah.
And to that end, or segue rather, is into the treatment algorithm. So you talked a lot about the different treatments that are out there for fibromyalgia. Can you talk about a few of them, some that you may feel like are vital when it comes to patients with fibromyalgia?
Totally. So there's the non-pharmacologic treatments, and there's the pharmacologic treatments. Non-pharmacologic treatments that have really good evidence that we should be talking with a lot of our patients about, not just fibromyalgia patients, but is giving them education about fibromyalgia. So what is it? It's a centralized pain disorder, and giving them that feeling of being heard. Really important. Educating them that it's not when you have pain, it's not that you have some condition that's degenerating your body. This is part of fibromyalgia. So education is important. Therapy, cognitive behavioral therapy has excellent evidence. So referring them to someone who can do that, or even doing self-guided cognitive behavioral therapy has shown good evidence, like on a smart device for helping in pain in fibromyalgia. So there's therapy. Another one is exercise, has really good evidence for it. Getting someone that's in pain all the time with movement to exercise is hard, especially and so I think defining what exercise looks like for them. This is not training for a triathlon or doing something wild. This is 60% max heart rate, 30 minutes, 3 to 4 times a week. And even that might be overwhelming for some people, a lot of people. There's good evidence for Tai Chi. That's a very achievable goal, I think, for our patients with fibromyalgia. And resistance training as well. So getting them moving, exercise is really important. Therapy and education.
I really enjoyed today in our meeting just talking about how this is like a central nervous system kind of involvement, and so keeping their nervous system calm. So educating them on sleep habits and diet, that all was really interesting, and I think something that we could better educate to help them have better outcomes.
Absolutely. And I think, if they're failing those or they're not satisfied with their pain, then we can move on to like medications, right? Personally, I would rather, if I could do things more naturally, that's what and most of our patients would rather not be on a medication. There are medications that can be used too, like tricyclic antidepressants, and Lyrica is on label for it. There are several, duloxetine. So there are several medications you can try, but we always want to try to minimize that aspect of it.
And I think the drive home message that I took away from today was validation and education.
Yeah.
And I think those are the two most important things that we as clinicians can do when we interact with a patient who either has been diagnosed with fibromyalgia or fibromyalgia is suspected. And I just really appreciate the time you took to come and educate us, and it really was eye-opening. So thank you so much.
Thank you. And I think those are excellent takeaway points, and I really appreciate the opportunity.
Yeah.